If you look at the ventricular septal defect, the ventricular septal defect can be classified, first of all, anatomically into inlet, trabecular, which is the mid zone, and outlet. You can also classify it as membranous and muscular. The question that they ask in our exams is, which is the one that is most common between membranous and muscular? And the logic is that at birth muscular types are most common, but they have a very high spontaneous closure rate. High closure rate. Because of the high spontaneous closure rate, because as the heart becomes larger, the muscle grows, the orifice becomes narrowed down. So because of this, the closure rate is very high. And for this reason, you will notice at birth, no doubt, the muscular types are more common, but what persists into adult life, because most of the muscular would have closed, it is the membranous that is the most common variety in adult. So one should carefully see, are they asking in an adult or are they asking in a newborn? Okay, so in an adult, the most common type is the membranous type. Another important point to remember is, what is this inlet, trabecular and outlet is? As you can see in this image, the inlet is basically connected to the atria and this atrial blood entering inside, and we're looking at the septum from the right ventricular side. So this is the inlet septum connected to the atria, close to the atria. You have the trabecular septum, and then we have the outlet, and this outlet is basically connected to the major vessels. So since we're looking from the right side, this is connected to the pulmonary trunk, and obviously if you look from the left side, it would be connected to the aorta. So this is how we classify based on where the ventricular septal defect is located, either inlet part near the atrial side or the trabecular part, or is it connected more to the outlet part that is close to the major vessels. Another important point to understand is this thing that you're noticing, this is the membranous type of VSD. This is where the membranous VSDs occur. One important concept that one should understand is that the outlet VSDs are associated with aortic regurgitation. Okay, this is an important point. That outlet VSDs are commonly associated with aortic regurgitation, thereby increasing the risk of endocarditis in some patients. It's important that we understand that VSDs can be also classified another way. They are classified as small, moderate, and large. Now, why this classification is important is the small VSDs are generally asymptomatic, and the large VSDs are generally the ones that are more symptomatic. So, if you look at the classification, this echo classification, small VSD is basically when the VSD size is less than 33% of the aortic annular size. Okay, aortic annular size. It's called moderate VSD if the size is between 33 to 75% of the aortic annular size. And it's called a large VSD if it's greater than 75% of the aortic annular size. So we compare the aortic orifice, the aortic annular size, and then look at the VSD, and based on that we are able to say whether it is a small VSD, moderate VSD, or large VSD. So this is another way to describe or classify the VSDs. Obviously here the important concept is the small VSDs are generally asymptomatic, is the large VSDs that have more left to right shunt resulting in earlier symptoms. Another way to classify the VSD is known as restrictive VSD. These are very small VSDs, restrictive VSD. We have moderate restrictive VSD and large VSDs, or rather non-restrictive VSDs. Non-restrictive VSD. So you have restrictive VSD, moderate restrictive VSD, and non-restrictive VSD. Now, how do we classify this restrictive? What do you mean by restrictive VSD and what's a non-restrictive VSD? How we classify this? To understand that, first let's understand what's happening in the ventricular septal defect. So if you look at the left ventricle, right ventricle, one of the important things to understand is ventricular septal defect actually simply is an orifice that is connecting the two chambers, left ventricle and right ventricle. And because of the left ventricle having higher pressures, close to around 120 by 10, this is around 25 by 5. So if you notice the pressure systole and diastole, you will understand there's a huge pressure gradient in the systole, and the left ventricular blood moves towards the right ventricle because of the huge pressure gradient with a lot of turbulence creating a murmur. So this is LV blood moving to RV, allowing extra blood to enter the pulmonary orifice. Okay, this is the aorta and this is the pulmonary artery. Now the idea is how much of blood will shunt across between left ventricle and right ventricle will decide ultimately how much is the pulmonary flow. If the shunt is small, if it's a small shunt, then the amount of blood shunting from LV to RV will be very minimal. And because of this lesser blood, the amount of extra blood entering pulmonary circuit, because now pulmonary circuit has to be blood picked up from the right atrium into right ventricle, that blood plus the blood that came from the left ventricle. So combined, the two bloods of RV plus the LV blood added is the pulmonary flow. And if you look at the pulmonary flow, normally the pulmonary flow definitely will be greater than the aortic flow or the systemic flow. Pulmonary flow will be greater than the systemic flow. Now, how we classify whether it's a restrictive VSD, meaning it's a small VSD, and a non-restrictive VSD means the gap is large, allowing a huge amount of blood to shunt across. The way we classify it is that if you look at the restrictive VSD, if you look at the amount of blood passing through the lung compared to the amount of blood passing through the systemic circuit, that is aorta, if the ratio is less than 1.4:1, that is a restrictive VSD. If the pulmonary to systemic shunt resulting in a huge shunting of blood, and this causes the pulmonary to systemic blood to be more than 1.4 up to 2.2:1, this is known as moderate restrictive. And if you find that the pulmonary to systemic flow of blood is more than 2.2:1, that means the amount of blood going through lungs is double that or more than double that passing through the aorta, then that definitely is referred to as a non-restrictive VSD. Now the important idea here to understand is that the small VSDs are less likely to be symptomatic, is the large VSDs that come with early symptoms. The question remains then, okay, what are the symptoms that we can anticipate in a ventricular septal defect? So if you look at the symptoms in ventricular septal defect, as I told you, if it's a restrictive VSD, that's a small VSD, most of these patients are asymptomatic. But if it's a non-restrictive VSD or a large VSD, then the symptoms can be quite early. So if you look at the symptoms, you can see particularly in infants, they can have features of congestive cardiac failure. In a child, the congestive cardiac failure features are very different from what we expect in an adult. So you typically don't expect a pedal edema or a raised JVP kind of scenario in an infant. What we expect in an infant in congestive cardiac failure is failure to thrive, excessive sweating, signs of breathlessness, okay, signs of breathlessness or um, fatigue during feeding. So all these are important ways of how congestive cardiac failure can manifest in a child. Also, we can see non-restrictive VSDs are more prone for developing pulmonary hypertension, and eventually the pulmonary hypertension will result in a reversal of flow, and that reversal of flow will cause a right to left shunt, and the right to left shunt is what we refer to as Eisenmengerization. This Eisenmengerization eventually will result in cyanosis and again congestive cardiac failure. Okay, cyanosis and congestive cardiac failure. So broadly, these are the features that happen, and because of the pulmonary hypertension and the right to left shunt, there will be cyanosis, and in an adult also you can see features of congestive cardiac failure occurring. To summarize once again, the symptoms in a VSD depend on how large they are. If the VSD is small, the amount of blood shunting from left ventricle to left ventricle will be minimal. If the VSD is large, then more blood will shunt across, more congestion in the lung. The more congestion in the lung will result in features of cardiac failure, which in an infant will appear like failure to thrive, sweating, fatigue during feeding. But in an adult will more likely to come with raised GVP, hepatomegaly, and pedal edema. And also you'll notice that this reversal of shunt is more likely to occur in large shunt. And this reversal of shunt is going to result in cyanosis and cardiac failure features. What are the signs that we expect in a VSD on clinical examination? So some of the important concepts that are being tested in our exam in ventricular septal defect is that we are seeing definitely there's going to be an excess amount of blood moving from left ventricle to right ventricle. This extra blood results in extra outflow to the pulmonary orifice. It's normal blood plus LV blood together is going into the pulmonary orifice. This extra blood ultimately comes back towards the left atrium from the lungs. And this extra blood is coming back is going to cause dilatation of the left atrium eventually. Extra collection of blood in ventricle in diastole also results in LV dilatation. This LV dilatation is the reason why you'll notice that the apical impulse is shifted outward. Okay, outward shift of apical impulse is mainly because of LV dilatation. Also, what else you expect in this is the movement of blood in LV to RV mainly happens to systole, as you can understand that the pressure gradients I was telling you, even if you take in a normal 120 by 10, this 25 by around 5 to 6 millimeter mercury, and you can notice the huge pressure gradient in systole. In diastole, the pressure difference is not much. So in diastole, the shunt does not operate. There's no turbulence, there's no murmur. The murmur occurs mainly in systole. And this is because in systole, you notice that the systolic pressure in the left ventricle compared to right ventricle, there's a huge gap. The very high pressure generated in the left ventricle throughout systole is going to jet the blood across into the right ventricle, resulting in a murmur, and that murmur that we auscultate is a pansystolic murmur. Okay, it's a pansystolic murmur. Now this pansystolic murmur begins with S1 and continues up till S2, because between S1 and S2 is ventricular systole. And you can notice that this murmur generally overshadows the sounds, and you can't hear the sound in the din of the murmur. You can't hear the S1, S2, and that's why it is referred to as a pansystolic murmur. This pansystolic murmur, the loudness of it depends on the pressure gradients. The simple concept is, if it's a small VSD, the smaller the VSD, the more the pressure gradient. The higher the pressure gradient, the more turbulence the blood will create when it's moving, resulting in a louder murmur, sometimes accompanied by a thrill. Which means a restrictive VSD might be accompanied with a more larger, louder murmur, and this is simply because the pressure gradients are more. In a non-restrictive VSD, if it's a large orifice, the blood moves from left ventricle to right ventricle more smoothly. The rapid movement of blood from LV to RV will equalize the pressures, and because of this, the blood does not move with turbulence, and the murmurs are very soft. So depends then the loudness of the murmur on how much pressure gradient is there between the two chambers. Smaller VSDs tend to make more noise because the blood will move with more turbulence. Larger VSDs, the pressure gaps between the two will rapidly close. For this reason, because without the pressure gradients, the movement of blood will be more smooth, not creating much turbulence, and this is the reason why you don't expect a loud murmur in a large VSD. Now it all depends on how big the size of the VSD is, because if you look at the amount of blood flowing through from left ventricle to right ventricle, that extra blood that is passing through the pulmonary orifice is not normal blood. it's extra blood because LV blood has got added to it. And this extra blood is going to create turbulence for the blood entering the pulmonary area. So you can also expect in these patients an ejection systolic murmur in the pulmonary area. Okay, an ejection systolic murmur in the pulmonary area. All this extra blood that went to the lungs, this extra blood from the lungs drains back to the left atrium. And this extra blood passing through the mitral orifice is going to create a relative turbulence because this is not normal blood flow across mitral orifice, is extra blood creating a diastolic rumble. This kind of a mid-diastolic murmur, which is a flow murmur, a functional murmur. This extra blood passing across mitral orifice is going to result in this murmur. This is diastolic murmur or diastolic rumble. And this is heard in the mitral area. Okay, this is heard in the mitral area. So let's summarize once again. What are the murmurs that you can auscultate in patients? Now it depends on how big the shunt is. Let's say we're talking about a large VSD. If it's a large VSD, then the pansystolic murmurs are not that prominent. They are present, but they're not as loud as what we would have expected in a restrictive VSD. The fact that it's a non-restrictive VSD, large movement of blood, although this will not create much turbulence, the pansystolic murmur is not that prominent, but extra blood passing through pulmonary area will result in an ejection systolic murmur in the pulmonary area. Extra blood that goes to lung comes back across the mitral orifice and left ventricle is going to result in a mid-diastolic murmur, which is known as diastolic rumble, and this is heard best in the mitral area. Okay, this is heard in the mitral area. Now, where is the pansystolic murmur heard? And I already explained to you that the pansystolic murmurs dominate when we talk about restrictive. In a restrictive VSD, the amount of blood shunting across is less, so less likely to get an ejection systolic murmur across the pulmonary area because less blood is passing through comparatively, and less shunt, less blood from the lungs. And because the shunt is small over here, I'm talking about a restrictive VSD, then the amount of diastolic flow of blood across mitral orifice also will be less. So if it's a restrictive VSD, what dominates is a pansystolic murmur. This pansystolic murmur is best heard in the left lower parasternal area. Now, why is it in the left lower parasternal area? Is because when you look at the ventricles, these ventricles, if you look from a cross section from above, you are talking about left ventricle and the right ventricle. And if this is the sternum, what you realize then is the right ventricle is just behind the sternum, the left ventricle slightly more posterior, and if there's an orifice, the LV pressure jets across in the front, and as it moves forward, this creates a huge turbulence coming in the front. So left parasternal area is the murmurs are going to be pretty loud. Again, obviously the direction of murmur and how the murmur is going to generate is basically dependent on where the murmur is, whether it's an inlet, outlet, trabecular murmur. So such detailed questions are generally not asked in our exams, but one should understand that a pansystolic murmur is best auscultated in the left lower parasternal area, and the reason for that is that the LV is behind the interventricular septum, the jet flows in the front, and this is the reason why the turbulence is auscultated best over there. So we hear the pansystolic murmur in the left parasternal area. We can also hear it in the mitral area. What else? What added sounds can also occur in a patient with VSD? You notice here that there's extra blood passing from left ventricle to right ventricle, extra blood going into the lungs, extra blood coming in the left atrium. When it enters the left ventricle, it generates a sound, and that is S3. So S3s are common in large shunts. Large VSDs, S3s are auscultated. S3 is present, and this is a left-sided S3. Okay, extra amount of blood collected in left ventricle results in a left-sided S3. Over a period of time, right ventricular hypertrophy will occur, and this is because the right ventricle undergoes hypertrophy as extra blood passing through the pulmonary orifice is going to result in changes in the vascular circuit in the lung. The pulmonary vascular resistance progressively increases. Now, why does this happen? This extra blood from quite some time passing through the lung is going to result in damage to the pulmonary capillaries, which are quite delicate actually. And this damage is going to be resulting in scar formation, fibrous tissue. As fibrous tissue proliferates, it will contract, and the pulmonary cross section keeps becoming smaller and narrowing of the pulmonary vasculature results in pulmonary hypertension. This pulmonary hypertension is a consequence of extra blood being passed through the lung for a long duration, and this pulmonary hypertension is going to result in right ventricular hypertrophy. Now, once pulmonary hypertension sets in, what we expect in addition is we are going to hear a loud P2 in the pulmonary area. Okay, a loud P2 in the pulmonary area. Initially, before pulmonary hypertension occurred, the A2-P2 split that is there because of extra blood passing from LV to RV. This extra blood to go out in the pulmonary orifice takes time, so the P2 would have got delayed. Because the P2 gets delayed, the A2 occurs on time. This I'm talking about S2. The A2 occurs on time. The P2 gets a little delayed. Why is the P2 getting delayed? Okay, why it is getting delayed is obviously extra blood coming in the right ventricle. Extra blood passing to the pulmonary orifice will shift the P2 back, and that's why you get a wide variable split in the initial phases of VSD. But as I was telling you, over a period of time, as pulmonary hypertension sets in, one of the features of pulmonary hypertension is the P2 is going to get delayed, and with right ventricular hypertrophy, the P2 starts occurring little earlier, rather not delayed, earlier, and this earlier P2. Why does early P2 occur in pulmonary hypertension? The early P2 is because the high pressures in the pulmonary circuit are going to close the P2 faster, and this is the reason why you'll expect that once pulmonary hypertension starts occurring, the A2 P2 come closer together, and the S2 split that was wide initially before pulmonary hypertension sets in will start becoming narrow. Okay, S2 split starts becoming narrow. One basic logic to understand is the very reason why A2P2 split occurred in the first place is the aorta is high pressure circuit, the pulmonary is low pressure circuit. That's why they are occurring separated. If the pulmonary and aortic pressure come closer together, then naturally the A2P2 also should come together. So the S2 is going to be a narrow split once pulmonary hypertension sets in. What else can you expect when pulmonary hypertension sets in? With the right ventricular hypertrophy occurring, there is going to be a parasternal heave that one can clinically detect, okay, which is a marker of right ventricular hypertrophy. Okay, right parasternal heave suggested to us that there must be a right ventricular hypertrophy. So all these things are likely to occur over a period of time as pulmonary hypertension sets in. As pulmonary hypertension sets in and right ventricular pressure progressively keeps increasing, and the RV muscle now is matching the LV size, then the pressure in the right ventricle might become equal to left ventricle. Sometimes you get a bidirectional shunt. Bidirectional shunt, part of the systole, the blood is moving from LV to RV, part of the systole, blood is moving back from RV to LV. Eventually, RV pressure will overcome LV pressure, and this is going to result in reversal of shunt. Once reversal occurs, then this is referred to as Eisenmengerization or Eisenmenger Syndrome. So Eisenmenger's is basically a reversal of shunt occurring in the VSD. The blood is now moving from right to left. The most important question that they ask in Eisenmenger's is, okay, what happens to the murmur across the movement of blood across the VSD? Remember the initial VSDs, we talked about the Pansystolic Murmur. There's a left to right shunt that was occurring. But now when the reversal is occurring, one should understand that the RV pressures must be slightly higher than the LV pressure. LV also has high pressure, don't forget that, because it deals with systemic resistance. And RV's pressure now must be higher than LV. That's the reason why right to left shunt is occurring. But the important point to understand is that the gradient between the two is not there. RV slightly higher than LV, and that slightly higher cannot move the blood with turbulence, and this is the reason why murmur will not occur. So it is a very important point to understand that pansystolic murmurs do not occur. Okay, do not occur when Eisenmengerization occurred. So this is a very important MCQ that they keep asking, that in Eisenmenger's can you expect a pansystolic murmur? The answer is no. In a right to left shunt, there is more deoxygenated blood passing through the systemic circuit, resulting in more erythropoietin secretion, and this results in polycythemia. There's another point that they ask, when does polycythemia occur? One of the mechanisms of polycythemia is a right to left shunt. Obviously, right to left shunt is going to result in cyanosis. Cyanosis and clubbing will start occurring. And the loud P2 obviously has to be there because the pulmonary hypertension is there. That's the reason why Eisenmenger occurred. The most important repeat question in our exam is what is contraindicated in Eisenmenger is you cannot close the ventricular septum now because whatever pressures on the RV muscle is very hypertrophied now. RV is finding it difficult to put the blood in the lung because of lot of narrowing of the pulmonary circuit. So whatever blood came to the right heart, right atrium, right ventricle cannot push out into the lung nicely because of pulmonary hypertension. So some of the blood decongest in the left ventricle. If you close that orifice, if you close the orifice, then RV has got lot of difficulty because of the pulmonary vascular resistance to put the blood in the lung. Residual blood will result in backing up of blood on the right side that results in raised JVP, tender hepatomegaly, pedal edema, which are all signs of cardiac failure. So cardiac failure features will start occurring if we close the shunt in Eisenmengers. So it is the main point, remember, do not close one cannot close the shunt, okay, the defect, whatever it is, ASD, VSD, whatever it is, we cannot close it once Eisenmenger has occurred. So this is an important concept to understand that in patients, we always do the closure of the ventricular septal defect before Eisenmenger occurred. Once Eisenmenger has occurred, closure of the septum is out of question. Okay, that will result in congestive cardiac failure. So these are all some important points that they ask in our exam about ventricular septal defect. The main points that one should be focusing on is the left atrium that will dilate and left ventricle that dilate, not the right ventricle. Right ventricle undergoes hypertrophy. That's one important question. Initially, when VSD was there, we noticed that the A2P2 split is white. This is because the extra blood came to right heart. Extra blood to pass out a pulmonary orifice takes time, so P2 gets delayed. So initially, there's a wide variable split in VSD, but as pulmonary hypertension sets in, the P2 starts occurring earlier and the A2P2 split starts becoming narrow. So definitely in an Eisenmenger, do not expect a split A2P2. It's going to be a single S2. And this is because the A2P2 are coming so close together that you hear it as a single sound. Not only that, the fact that both of them are banging close at the same time results in the din of the sound to be very loud, making the P2 to be loud. So one of the explanations why the P2 is loud is not just pulmonary hypertension, it's also because the A2P2 is shutting almost at the same time. And this is a good image showing what are the things that are happening in Eisenmengers, and you can see that initially the left-right shunt out is there. Okay, this is left-right shunt. Extra blood going through the pulmonary orifice generated a murmur across the pulmonary. A pansystolic murmur was present across the movement of blood from left ventricle to right ventricle. This extra blood that went in, that was coming back across the mitral orifice, also resulted in turbulence because of the extra blood passing through. So there's a mid-diastolic murmur that we saw, and all this is happening in the high flow circuit zone. But once the pulmonary hypertension starts occurring, then you notice that the flow of blood moving from the left to right slows down and the turbulence also comes down. As the RV pressure starts rising, the gap between the two LV and RV becomes narrower. The blood doesn't move with so much turbulence now, and this is the reason why you don't expect loud murmurs once pulmonary hypertension starts setting in. So what happens is you notice the pulmonary orifice is quite large, but over a period of time you notice this pulmonary orifice that was large becomes narrow, and this progressive narrowing of the pulmonary orifice, this progressive narrowing is going to build up huge pressures in the pulmonary circuit. The RV starts undergoing hypertrophy. Look at the right ventricle initially in this image, and look at the right ventricle size over here. And as the RV starts undergoing hypertrophy, this is going to result in a reversal of shunt, and this reversal of shunt that is occurring is going to result in cyanosis, and this deoxy blood is now coming to systemic circuit. Okay, so this is basically the Eisenmenger syndrome, and this is how it is occurring. So the idea obviously is that much before Eisenmenger has occurred, the septal defect should be closed. So the broad concept is when the pulmonary to systemic flow is more than 1.5:1 and if patient has symptoms, then one should go for closure of the VSD. Or if the patient has no symptoms but the shunt size, that is the pulmonary to systemic, is more than 2:1, then also closure is required. The one place, as I told you, where VSD closure is not done is when patient has already gone into Eisenmengerization. So what the X-ray will show in these patients is a dilated left atrium and a left ventricle with right ventricular hypertrophy. Eventually, the LV also will start becoming thicker, or rather it was thick already, so biventricular hypertrophy changes might occur in the ECG. Also, echocardiogram obviously is going to be a very important investigation in any cardiac structural defect and tell us about exactly how big the defect is and where it's located. Finally, the procedure that we do is a closure of the septum, and this closure of the septum, as I told you already, cannot be done once Eisenmengerization has occurred. So these are some of the important points one should remember when we're talking about ventricular septal defect.